national conference as well. So this is like being broadcast over Zoom so people can hear side conversations, but I also want participation, so feel free to just speak up. So I guess people on Zoom might know, but the board team doesn't know. I usually start my conferences with a piece of art. It's a good way to like kind of break up the day, have something fun to look at. So this is actually just a detail from a self-portrait by a Dutch female artist from the 1600s, which I think is just super cool. Her name is Judith Lester. It's from 1630. It's actually, you can go see it in the National Gallery in DC when we can go places again. And she was highly acclaimed for her technical skill, actually had her own workshop and paying students, which was incredibly rare, as you might imagine, for the Netherlands in the 1600s. Sad part about the story is she married another artist, and after getting married, never made art under her own name again. They think she probably made art that her husband took credit for. So some things change, some things never do. Today, we're going to talk about an approach to weakness. This came up because we were talking about review of systems questions and how to differentiate between weakness and fatigue earlier in the week here at Denver Health. And there happens to have been a recent patient on the wards here where this became a very pertinent issue. So first we're going to go through and talk about ways to think about and approach weakness, and then we'll go through the case. I don't know that this case is going to take the whole time, but we'll take as much as we need to get through it. So today, really just the learning objectives are learning how to identify a patient presenting with signs and symptoms of weakness that are concerning for an underlying neuromuscular pathology, and then develop a systematic approach to the evaluation of that weakness. So asking for participation from the folks out in the virtual world as well as in the room. How do you think about weakness?
Start with focal versus generalized.
Excellent. So focal versus generalized. And what kind of questions do you ask, Barry, to get that?
Have you noticed any changes in the way you're able to move any particular part of your body?
Awesome. I think that's a really good question. I don't know if I've heard that one before. So any changes in the ways that you're able to move any parts of your body? I like that because it's general. The patient completely understands that language, and they're going to say, oh yeah, I can't lift my arm up, or I can't do this. Other questions that can be helpful are like, are there things that you used to be able to do that you can't? Or do you need help with any of your activities during the day? Those kind of start to get at if you're weak or just tired. Oops. So the steps to evaluating weakness kind of by neurologic and internal medicine guidelines are to classify between weakness and lassitude, localize the lesion, and then determine the cause. So lassitude, I included it because I think it's a fun word, is really just physical and emotional fatigue versus a quantifiable objective strength deficit. The first step, again, differentiating weakness from fatigue. Beyond those questions that we already talked about, are there other questions or other ways you think about asking a patient and trying to decide, are you just tired, which is completely reasonable. For all of those who aren't at Denver Health, our patient earlier in the week complained of generalized weakness and fatigue, and we found out he worked in construction and worked kind of 12-hour days, 6 days a week. So that was more of an understandable fatigue pattern. What kind of things do you expect in a patient who's weak, or what kind of things might you want to ask a patient?
Like chronicity of it? Is this something that happened acutely, or has it is it getting worse over time, gradually progressing, has been going on for a while?
Excellent. So that the pattern, fatigue tends to be kind of it's always there, maybe a little better, maybe a little worse. Weakness, probably they can identify a time when it started, or at the very least are going to say it's stayed the same, gotten worse gradually over time. other keys to the differentiation between a weak patient and someone who's got lassitude or just fatigue. They do typically identify difficulty with specific tasks. Common ones are brushing hair, putting things on high shelves, carrying groceries. Rarely is there pain involved, and rarely do they have local or any kind of specific tenderness to palpation on exam. I would say tenderness to palpation is probably is the least specific of these, and certainly if you do find tenderness on palpation of exam, I wouldn't immediately exclude weakness. And then just a reminder, even our cachectic patients with advanced malignancy should still have full strength. Just because you're very thin does not mean that your muscles are not working as they normally do. So with that, do you guys remember, and looking at, when I looked at the scale, I realized I didn't remember as well as I thought I did. Do you guys remember the scale and how we grade strength in the neuro exam?
Against gravity.
Yes.
Always my baseline.
Yeah, exactly. That's like, yeah. So I can remember like 3 is against gravity, 5 is full strength. Another key that I found in getting ready for this is everyone, all of our adult patients, I can't speak to pediatrics, but adult patients should always be able to completely push against resistance when they abduct their arms at 90 degrees and lifting, flexing and extending their hips. I think I realized, like, I give people passes on that sometimes, like our little old ladies, people like that, and that actually is a deficit. It's one thing if you're like really muscling against them, but they should be able to resist your pressure. So it's a scale of 0 to 5. I think I actually thought it was a scale of 1 to 5 before this. But 0 is there's no muscle contraction. 1 is just trace muscle contraction. 2 is movement only when gravity is eliminated, which is tricky. So that means that you're, like, if you lift up their arm or support their wrist, then they can flex it, but that they can't like lift it off the bed on their own, or they could maybe move their arm above your arm if you held it, but they can't lift against gravity. It's that like initiation strength, because it does take more strength to initiate than continue movement. And then 3 is exactly like Meryl said, movement only against gravity. 4 is reduced power and strength against resistance. This is a little more subjective, but it's helpful to, again, to know that they should be able to resist you completely if they have full 5 out of 5 strength. And 5 is that full strength against power and resistance. So then the next important thing to think about is localizing the lesion. Just as a reminder, the lesion in weakness can be anywhere from the motor cortex all the way down to the muscle, with every branch point in between. And we'll talk about when to think about or how to evaluate each of those different points later in the presentation. And this is incredibly important because it narrows the differential diagnosis. I really like this table. It breaks it up in like category of disease as well as the site of lesion. And you can imagine it's much more difficult if you're just looking at this entire list of differentials than if you say, okay, I'm pretty confident that this lesion is at either the level of the neuromuscular junction and muscle versus it could be anywhere. So I think this really makes the case for spending some time to differentiate a lesion early on rather than doing, as Dr. Linus says, the gropogram. And then this is another nice table, just kind of quick, the earliest evaluation of your weakness, thinking about, do they have objective muscle weakness on exam? If no, then worry about other classes of disease. It doesn't mean you ignore them and say, oh, you're fine. think about things like cardiopulmonary disease, anemia, infection, malignancy, depression, deconditioning, fibromyalgia, which are all still real medical conditions. But if they do have objective medical findings, then you want to determine if it's more of a generalized weakness or if it's localized. And once you have localized findings, differentiating between symmetric, asymmetric, and determining if there is a specific pattern, often that pattern tends to be in the, let's see, what are they? The fasciculo-scapulohumeral, scapuloperoneal, or scapulohumeral dystrophy pattern. Okay, well, this is fun. I'm sorry, Denver Health just got disconnected. I hope everyone else is okay. I'm gonna take a pause really quick here and try and help Denver Health. Oh, back on, okay. So those have like a very specific pattern. If you're thinking about like, oh, they have weakness in at their forearm and their lower leg, or at the shoulder blade, leg, and arm. Otherwise, you want to differentiate between proximal and distal muscle weakness as ways to determine next steps in your evaluation. Okay, so on to the case. And again, I want to highlight, I chose this case because I think it's an unusual presentation that highlights a lot of the importance of a systemic approach to every patient, even before you have a differential for them. So this is a 68-year-old gentleman with a past medical history of prediabetes and hypertension. He's coming in through the ED for syncope. So he was standing in line at Metro PCS for like 20 minutes. All of a sudden things got dark, and the next thing he knew, there were a couple ladies standing over him. He's never passed out before, doesn't have a history of chest pain, shortness of breath, denies any feeling like his heart's racing, any palpitations. Per EMS, who talked to the people who were there when he passed out, there was no observed seizure activity and no incontinence of bowel or bladder. He did hit his head when he fell and has a small scalp laceration. Otherwise, he says, like, I guess I eat less than I should. He has 15 pounds of unintentional weight loss at a recent PCP visit. So he went from 238 to 223 in the space of a month. Prior to that, he'd lost 30 pounds intentionally over the course of a year after being told that he had prediabetes. And then he does say he has some difficulty swallowing kind of everything, but denies any choking, regurgitation, coughing, no nausea, diarrhea, hematochezia, and review of systems is otherwise negative. Do any of our friends in the virtual world want to chat, or anyone in the room have additional HPI questions? And I'll follow the rules that I gave the Denver Health Board team earlier in the week, that if we know this at this time in the case, I will let you know. I'm not going to hold anything back, but I am also kind of keeping to the timeline of when information came out. Any other questions? Not mentioned, but he denies. What are you trying to get at? Okay, excellent. Yeah, because it does that with that like sudden darkening. It sounds very orthostatic. And so he says like, I think I drank some water. I don't feel lightheaded, and he did get orthostatic vitals that were normal. I think they were a little borderline, like maybe 10 points in systolic, but not the 20 points. Didn't meet criteria. Great question. Okay. And I think like, especially with a patient presenting with syncope, this is a really reasonable HPI. I'm not trying at any point in any of my presentations to criticize providers who cared for the patients, just making sure that we all like apply our systematic approach as well. So other history for this patient, he does have a history of hypertension and obesity. In the chart, his BMI was 30 to 34.9. At this visit, based on since his last PCP visit, his BMI, I think, is down to 28 at the time of this visit with that recent weight loss. And then that history of prediabetes, his A1C was 5.6 with that prediabetes diagnosis. So his PCP is super on top of it. Past surgical history, none. He doesn't have any known family history of GI problems or malignancy. Social history, he says he's a former smoker. He quit at like 18 with about maybe a total of a 2-year pack history. And he denies any alcohol or drugs. He says he's allergic to ACE inhibitors. Sounds like he had angioedema with that. And then medications, he takes aspirin, amlodipine, hydrochlorothiazide, betamethasone cream, and cetirizine. Any questions from this?
Any recent changes in his medications?
No. And why do you ask?
I don't know if they just went up on his blood pressure meds because.
Excellent. Yeah, I think like many attendings and many providers, and I completely agree, like if something happens to a patient, find out if we did it to them. It's especially true in the hospital, but equally true of people coming into the hospital, especially someone who's on a pretty, not, I wouldn't say incredibly intensive, but a reasonable hypertensive, 2 reasonable hypertensive doses. Yeah, and so great question. He's been on both of those medications for years at this point, since he had that angioedema to an ACE inhibitor like 5 or 8 years ago. Any other questions? Cool. And I think the one thing I would highlight, and I am guilty of this as well, is I look at the cetirizine and the betamethasone cream, and I'm like, yeah, a lot of people have that. And that's exactly what happened here. I think, and I don't know that checking it would have made a difference, but especially in a patient like this who has only 5 medications, it might be worth asking, oh, why do you have that betamethasone cream? And if you asked, you'd find out that he has a scaly rash on his back or his trunk, arms, and legs for the past like 3 or 4 months that responds to the cream, but as soon as he stops it, it comes back. But that wasn't noted at this time. I think another provider a day or so later finds out. So his exam, I apologize, I didn't highlight the abnormalities here. And I realize I think in some of the labs I may not have as well, so my bad. But he is afebrile, a little bit tachycardic at 107, mildly hypertensive, 135 or 94, sitting well on room air. Overall, he appears comfortable. He does have that small laceration on his scalp. I don't think it required any sutures. And by the time the first medicine provider saw him, he wasn't bleeding even. He has some trace lower extremity edema, but otherwise unremarkable. And this is, any questions on this exam? Or any other things you'd like to know? Patient coming in with syncope. Yeah, I think so. And yeah, I think there's all the mild abnormalities. I wonder if this was maybe just like he's still a little adrenergic from syncope. Overall, he sounds like he appeared very reassuring. He got, I think, a liter of fluids in the ED, and by the time he got to the floor, his heart rate and blood pressure had come down. He didn't require any oxygen.
Along the lines of what Meryl was saying.
Yeah.
Always check orthostatic vitals if they're in for syncope.
Yeah, excellent. And I think they were checked when he got to the floor, which is maybe less helpful because he'd already gotten his liter of fluid, but that's when they were negative. Rash. That was not noted. This is all I had for the exam on admission. So at this point for our gentleman with syncope, how do we want, what are we going to evaluate him? This is not a trick question. Everyone does, we do this. I just want to reinforce. We get EKG, echo, put him on tele, orthostatic vital signs. What else? Anything else? Glucose, excellent. Okay. What was it? Electrolytes. Okay, great. So yeah, I agree. Just kind of like the general syncope workup. I think, again, retrospectoscope being 100%, I would be interested in a full neuro exam here. And I think like looking at society guidelines, every admission for syncope does merit a full neurologic exam, not only to evaluate for potential etiologies beyond those like cardiogenic things that we're most worried about, but also evaluating, especially in the case of a gentleman who fell and struck his head, if there's any new focal deficits. And I think, again, every patient coming into the hospital merits probably a relatively full neurologic exam. So these are the initial labs he got. I will say the hep serologies were added on after that AST and ALT came back slightly elevated. But this is kind of, he came in the after, I think he was admitted on a swing shift. And so they had overnight to add on a couple more labs. And this is what the providers have in the morning when they come in. Anything remarkable standing out to you? That's like,
0.7.
yeah.
I think that's real.
Yeah, it's real, but it goes down. And we'll look at his EKG too. Yeah, and I've talked with Andrew Levy. He's gonna come, I think, this month, hopefully, to talk with you guys about the new troponin and how to think about troponin. And it seems like this is, you know, it's hard to interpret. Again, if we got a 0.7 before it was a 700, and they're not complaining of chest pain and have a reassuring ECG, you could maybe make a case for not trending it, but now once it's going down, generally reassuring. Also with that elevation in BNP, I think we talked about a few days ago, in obese patients, smaller elevations can still be indicative of heart failure, but this is a really, really small elevation. And we're gonna get an echo for the syncope anyways. I would say overall, these are not incredibly concerning labs. There's nothing that stands out as something that merits significant additional evaluation immediately. I think it was wise to add on those hep serologies for the LFTs. And I will admit, I was a little surprised that he didn't have a previous CBC, so we didn't know his baseline hemoglobin. But in thinking about this gentleman from the PCP perspective, he's a healthy 68-year-old without any signs or symptoms concerning for anemia. So you can understand why it wasn't done. Oh, it looks like we had a chat. CK, great. So Bill's asking about a CK. And can you type to us or shout out? I might be able to hear you. Why are you interested in that, Bill?
Sorry, I just shoved a tomato in my mouth. Because he has an elevated AST, which could also be a muscle marker, and his creatinine's up, and he's syncopized.
That's excellent. That's a really, what will turn out to be a very pertinent point. You're a plant, Bill. But unfortunately, at this time, the CK wasn't chosen. And I think, again, I understand why it was done, but if we're being really careful and thorough, I think it's a completely reasonable lab to add on. In thinking about this in terms of value-based care, the CK, especially in light of these other labs, is not incredibly expensive, not going to delay his care or significantly add to the cost of this admission. Excellent. Okay, so then here's his ECG. Would one of we don't have too many interns, is one of the interns in the room, Sam, I'm looking at you because you're right in front of me. Are you willing to read this? And it's not a trick.
Sure. So the first thing you want to do is always confirm the patient for the campaign. But after that, so looking at the rate, so oh god, there's a lot of them there. I would be able to find the number of them by 6.
Yeah, I can show you. It's if we go 300, 150, it's a little over 100.
Okay, so a little over 100. Next thing, looking at axis. So there's a normal axis that I want to do. Next, looking at there's a P or QRS after E. Yeah, so these are for science. And looking at intervals, the QTs seems a bit long.
I think it was on the longer side. I think it was like 490.
Okay.
We won't maybe slam him with Zofran, but yeah.
And then looking for any ST changes. Here. Looks like ST depressions in more in college. I don't think so.
Yeah, I think that you could, it's good to think about that. It's more maybe like a slurring, but
Okay.
yeah.
Yeah, so putting things together, sinus tachycardia.
Excellent. That's exactly what it is. It's sinus tachycardia. And I love that even though you look at it and it's like, oh, that's sinus tachy, you went through it systematically, because that's like, there are really more subtle changes like T-wave inversions or isolated ST depression, things like that, that we might miss. So excellent job. And I'll say, this was his first ECG, and then he had 2 others with the other 2 troponins that were virtually identical. So pretty reassuring against arrhythmias or ischemic disease. And then he also got a chest X-ray. Any of the, do we have any of the sub-I's here? Awesome. Well, he just raises his hand. So are you willing to read this chest X-ray for us, Jesus?
Yes.
Awesome, thank you. Okay,
It
Cool.
helps with
And-
assessing the rotation.
yeah, perfect. And try and speak up so folks can hear you. I think Sam was in a good place, so.
Sure. So I learned in my WIC ABCDEF.
Okay.
So rotation, look at the clavicles, and it doesn't look like it's rotated. Inspiratory effort looks pretty good. You see like the 8, 9, 10-ish rib.
Yeah.
Penetration, the vertebral bodies to me kind of disappear pretty
Mhm.
early on, so
Yeah.
maybe it's a little under penetrated.
Yeah.
The airway looks midline, below and above the clavicles from this far away. The bones are somewhat not visible in over the right area.
And I'll say that's a weird artifact. You can look on my screen. There actually are. The Denver Health screen
Okay.
obscures like the 3rd through 6th rib on the right side for unclear reasons, but they're there.
There's a mass in the television.
Yeah.
So I'm gonna just guess that the bones look fine, but I would take the time to look at every single bone.
Yeah.
And make sure that there weren't any fractures or
Yeah.
old healed weird anatomical stuff. Cardiac silhouette, really hard to assess from this far.
Yeah, and if
But-
it's a AP, so it's hard to say for sure, but
I'm gonna say there's no cardiomegaly.
yeah, it's not massive.
Yeah. So next one is the diaphragm. I can see the costal phrenic angles, maybe a little blunted, but the diaphragm looks complete. It doesn't link tear. The right side is a tiny little bit more elevated than the left, which is normal. No like viscous perforation. E is for extra. So that's just looking at all the like lead buttons, like pigtail catheter or anything like that might be there. All I see are EKG leads.
Great.
And then F is the focal field, so that's finally looking at the lines. There's this weird, like, dark spot in the right upper lobe that probably doesn't belong there.
Yeah, that's just the artifact.
There's otherwise pretty good lung parenchyma to the edges on both sides, I think. Yeah. The costal phrenic angle is not blunted on the right side. It is a little bit opaque. And maybe the same thing on the left, but it's a little bit cut out.
Yeah, and you already mentioned it's a little underpenetrated, so it's hard to say.
And then there is like some notable like opacities, like hyperlucencies in the right, like bronch.
Yeah, like that parahilar fullness.
Yeah.
Yeah, that wasn't really commented on. It was, I think, what overall great read. It was read as normal.
Yeah.
And again, I like it looks normal when you look at it, but taking the time to go through systematically. And I think again, always remembering like once you comment that maybe it's a little overpenetrated, being like, then it's harder to say about opacities. So we remember he got the echo, I forgot, which I didn't include because it was completely normal. No ASD, normal bubble study, normal EF, no ventricular thickening, no valve abnormalities. But while he was here, the nurse called and said, like, I think that first night, like I gave him dinner and he can't eat it. He's just choking. So speech language pathology came And we're like, yeah, it doesn't seem like he's eating much. Let's get a barium swallow. And it was the most detailed barium swallow report I've ever seen. It was like 4 pages, but this is the summary. That during all of the trials, the epiglottis was noted to be nearly completely stationary, remaining in place, opposing the posterior wall of the pharynx. Occasionally, the epiglottis closed in a delayed fashion. It was significant for impaired pharyngeal swallow with absence of normal epiglottic tilt. So essentially, this is like some posterior oropharyngeal dysphagia, which is not incredibly common, I would say. And so, do you guys? What do you think about that, or what are you going to do next?
I think he needs like a full neuro exam at this point to figure out if it's like isolated to your pharynx or if there's like other neuro deficits.
Excellent. Yeah, so Meryl wants to do a full neuro exam, making sure that you're determining if it's isolated or if there's other deficits. I think that's reasonable, and that probably, I agree that it would be great if that was done at this point. However, instead they had speech language pathology came back. And they said suspected neurologic diagnosis due to the severity of the swallow function and weakness. And really don't know what more to say until they're more completely evaluated. And at this point, given that swallow study really identified deficits in the posterior oropharynx, the team decided to call ENT, which again, I think is reasonable. They're the folks who can do a direct scope at the bedside. So they came by. And from here on, I'm just going to include the new information that we get from any of our consultants rather than rehashing the story. So again, I thought this case was about weakness. I promise we're getting there. And I think Meryl's question of a full neurologic exam is a very pertinent point that would, again, be one of my learning takeaways for this, that the sooner this was done, the sooner we would have gotten a final diagnosis. So ENT comes to see him. They find out that patients were reporting 3 weeks of dysphagia. And in their note, the resident describes significant pooling of secretions in the posterior oropharynx, which is again a sign of dysphagia, difficulty with swallowing. They said no interventions. They can't rule out an esophageal or lower airway pathology at this time. So they would recommend evaluation of the lower esophagus, which I think makes sense. I think the barium swallow is really more sensitive for abnormalities of the epiglottis because they see it in real time. And it can be hard when you're just looking with a scope to say like, oh, normal, abnormal from moment to moment. So then GI came to see him. They found out for the past month, he's been cutting his food into incredibly small pieces in order to be able to swallow it. And they said concern for esophageal motility abnormality versus oropharyngeal dysphagia from a CVA. They wanted to get an EGD then to rule out for an anatomic cause of the symptoms. By this point, he'd had a CT just of the neck and esophagus that was unremarkable. No CT had. So the EGD from that day was overall unremarkable. There was no clear dysmotility. There was some esophagitis, kind of in the medium to moderate range, and then a single nodule in the lower third of the esophagus. They did take biopsies because they were there and evaluating it. I had trouble seeing the nodule, and I think it was right there. They think this was a post-cautery picture. So now who do you think we should call? Or what do you want to do next? I would still vote for a full neurologic exam. And neurology finally did see him. And in their note, which is not at all surprisingly, very helpful descriptions of some of this dysphagia. They described it as every swallow of every meal. throughout the course of the day, which I think is really helpful and not a way I'd thought of asking about dysphagia in the past. This was the first time there was mention in this admission of that flat scaly rash. And I apologize, these pictures are not great. I tried enlarging them, but they could just get grainier. It is a pretty flat rash, nothing that was remarkable or that stood out in any way. And family history was just elaborated here to confirm no other neurologic or autoimmune disorders that he was aware of. And then we did find out that he was not currently drinking alcohol, but prior to 2 months ago, drank 2 or 3 drinks a day. And finally, the neurology exam. So here, I think is incredibly interesting. They just noted mild dysarthria. This was the only provider to note that. And I think that can be subtle and difficult to determine between just maybe an accent, an affect, and a dysarthria. And I don't know exactly what about his speech made them call it dysarthria. And then motor, they said normal bulk and tone bilaterally, and he can abduct his arm to 50 degrees, so about halfway from hip to shoulder. But he can't lift it beyond that. And if you lift it to 90, it gradually drifts down. He can't bring his arm above his head. And he did flex his shoulder to kind of cheat and bring his arm up higher, but he can't actually lift his arm up. His reflexes are abnormal. He has no brachioradialis or Achilles reflex, and the plantar responses were muted bilaterally. And then he has bilateral proximal muscle weakness at his shoulders. Bill, did they check hip strength? Oh yeah, so sorry, this was just the easiest thing to include. Everything else was normal from strength. So it's just proximal shoulder weakness. Any specific reason you ask about the hip strength, Bill?
Because with rash and shoulder weakness, I think of like dermatomyositis.
Yeah, excellent. So I think that's very reasonable. And they did check, it just was normal. So from here, let's go back to this differential diagnosis of weakness and evaluation and think about what we think could be going on. And I think this is tricky. I think the helpful thing here is saying we have objective findings of muscle weakness that are bilateral and symmetric in a proximal distribution. With that, where would you start to localize this lesion? Do you think it's going to be in an upper motor neuron distribution? No. Perfect. And why not? Just be very explicit about this. Yeah. Yeah. Excellent. What about in an anterior horn cell? Symptoms? Yeah.
He said no fasciculation.
Yeah. Yeah, exactly. So again, we're still looking no upper and lower symptoms. Great. And then what about a peripheral nerve? Yeah. Neuromuscular junction? Yeah. Muscle? Yeah. Perfect. And I think that's kind of the way this typically goes is you generally go, I would say peripheral nerve is almost always included in the initial differential. And it either goes towards the more peripheral area of the neuromuscular junction muscle or peripheral nerve, maybe anterior horn cell, upper motor neuron. And just for completeness and to be thorough, how would you evaluate if you were worried about upper motor neuron, anterior horn cell? What's the next step in studies that we haven't gotten so far? CT, it's imaging. Most often it's going to be a CT head. You might need to get an MRI if you're worried about something more in the cerebellar region. You can also things like x-rays if you're worried about spinal abscesses. But key is imaging. And that's also the answer for anterior horn cell. The other procedure that you might need to think about is an LP to get CSF and evaluate, especially for things like paraneoplastic or abscess. Okay, great. And so now, when we're evaluating for a peripheral nerve, neuromuscular junction, or muscle etiology of this weakness, what do we want to do? Yeah, so I think that we want all of us like definitive answers, and biopsy of either a nerve or a muscle is the most definitive answer. However, it takes time and it's incredibly painful. I think that's one procedure that I've had pretty stoic patients who haven't complained about pain and don't really complain about pain after a nerve or a muscle biopsy they're uncomfortable. So yes, but what else can we do first?
Antibodies,
Yeah, antibodies and LP. EMG, excellent. Yeah, so the I can never remember it. It's watching the electrical conduction through the muscle and measuring the rate of response at the neuromuscular junction, which is for some reason easier to say. Excellent. And so you guys got to the same place as neurology at this point. They said 68-year-old gentleman, the blank spaces are his name, that's why it's not there. Exam pertinent for dysarthria, proximal weakness, hyporeflexia, constellation of symptoms suspicious for Lambert-Eaton, occasion which may have bulbar involvement, history and rash, suggestive of myositis, dermatomyositis, polymyositis, or autoimmune myositis. Thought about all of those other central things, but didn't think it was likely. And then this is the attending addition. He at this point, by the time the attending had tested, his CK was back, but the poor resident didn't have it. He did have an elevated CK, and very much along the lines of what Bill said, that was attributed to be the etiology of the elevated LFTs. And then they wanted they got an EMG, and that was just a bedside EMG, which I don't know how to include, that said it was consistent with inflammatory myositis. I will look up and try and find more information. I wasn't able to get an answer from neurology about what made that consistent with inflammatory myositis. But so they said recommend steroids, and then a pretty full rheumatologic pattern, with the idea being mixed connective tissue disease, systemic lupus could all be potential etiologies of this. So he got a pretty thorough workup. The ANA was positive, and with that titer of 1 to 1280, is that really positive or not very positive? Yeah, it's very positive. Yeah. So you think, and I always have to like take a second and remind myself that that's the dilution. So like 1 to 2 positive, you're kind of like, okay. And actually I think for ANA, it's like up to 1 to 20 dilution can still be normal. But this is that they diluted out 1 to 1,280 aliquots, and it was still positive. So that's very, very positive. Otherwise, really unremarkable. That low C3, that low complement is not, especially in the case of like acute inflammation when it's so mildly low, not something that they dealt with further. And he also had an acute myositis panel sent. So that's looking for really autoimmune etiologies, and it came back with an MI2 antibody positive. So he was ultimately diagnosed with an autoimmune myositis. He's now been on steroids for about 2.5 weeks, and his dysphagia is getting better between speech therapy, and then he hasn't had, he was seen right after he left the hospital, and he's going to be seen by neurology and rheumatology again next week, but he thinks that his proximal muscle strength is getting better. So hopefully kind of today we talked about approach to evaluation of a patient with weakness and differentiating objective findings concerning for neuromuscular etiology versus subjective weakness, and then started to define a systematic approach to that weakness. I think the key learning point for me from this case was even when a patient presents with syncope, making sure we do a full neurologic examination and recognizing that dysphagia, it can be a form of neuromuscular weakness, not just a complaint related to isolated GI or oropharyngeal symptoms. Any other questions or concerns?
Can I just ask about like the E2 comes back?
Uh-huh.
And are you sure it's autoimmune or when you go looking for like a cancer?
Excellent question. So Meryl's wondering, okay, Me Too comes back, and we just say, great, it's autoimmune and move on with our lives. And yes and no. They do, as long as he's responding to steroids, easy for me to say. But he'd never had a colonoscopy before, so they're gonna do that and monitor closely and they are attributing the weight loss to just not swallowing anything for a month. But they'll monitor very closely and have a low threshold if he had a new localizing symptom to evaluate pretty fully for an underlying malignancy. I think the other reassuring thing was his, although he had a mild anemia, his MCV was normal, and he had other evidence of appropriate blood cell production. Cool. Nice work, guys. Thanks for joining us. And I hope you all have a wonderful weekend. As a reminder, it's Labor Day on Monday, which I recognize means not very much to most of us, but it does mean there won't be conference. And then ask site specific in terms of lunch or not.